Okay, I'd like to go through this patient's preoperative MRI scan. Basically, he has a lumbarized S1, and this is what I'm calling S1. This would be S2. This would be L5. And this is what we would call a sagittal section. And what it shows is that the patient's disc space is collapsed posteriorly. There's a little bit of retrolisthesis where the L5 vertebral body is behind or posterior to the sacrum. And as we scroll through here, you can see that the opening above for the nerve root is larger than this one, and there is some element of foraminal stenosis, mild, and the posterior annulus is bulging back posteriorly. What we've done is we've indicated this patient for an anterior lumbar interbody fusion. As we're looking through these images in the axial plane, at L5S1, there is some thickening of the facet joint capsule. The L5 nerve root gets out fairly well. It perhaps is slightly narrow. The facets show mild to moderate degenerative change, and you can see that there's a small midline buckling of the posterior longitudinal ligament and probably a small central herniated disc. This is the thecal sac. This is the left L5 nerve root that's already exited. This is the right L5 nerve root. This is the psoas muscle, the iliac artery, iliac vein on the left, iliac vein and iliac artery on the right. Our approach for the anterior interbody fusion is going to be from the left. These are the preoperative plane x-rays on the patient on whom we're going to operate. This is the abdominal contents. This is anterior, posterior. This is the vestigial disc space that we'll see on the MRI scan that we labeled S1, S2. This is where we've labeled this L5, S1. The normal disc height we can determine from the L3-4 and L4-5 interspaces. At L5-S1, this disc space is considerably narrow. There's some retrolisthesis of L5 on S1, and we'll also see that in the MRI scan. This disc space is probably 50% collapsed relative to the normal disc spaces above. Our intended operation today is going to be to take this disc out from an anterior lumbar interbody fusion. We'll use the Staliff intervertebral cage and screws to reestablish the height and establish lumbar lordosis. This is the spinous process of L5. This is the spinous process of S1. We will do a posterior interlaminar decompression. We will smooth off the inferior aspect of this spinous process and then insert the coflex-F implant. This is the AP view of the patient's lumbar spine and pelvis, normal iliac crest height, and you can see that the height of the crest is considerably higher than the L5-S1 disc space, which is right here. This disc space is the vestigial S1, S2. The patient has normal alignment. Hips and pelvis are otherwise normal. In the operative procedure that we'll video today, we will be putting an intervertebral cage in at L5-S1, and the coflex-F device will go between the spinous processes at this level. After the anterior cage is plated and stabilized with screws, the patient's wound will be dressed, closed and dressed, and then the patient will be turned into the prone position or abdomen down. We will be looking at the patient in the video in this orientation, and we will be able to see the spinous processes of L5 and S1. We are going to remove the ligament complex between those two bones. We're going to remove a small portion of the bone here and here so that we can actually see the underlying neural canal and the soft tissue that overlies the nerves called the dura. To stabilize the posterior spine, we're going to insert an implant called the coflex-F, and this is an example of that implant. It's a curved titanium implant, And this implant is intended to be placed down so that the curve is deep down within 1 millimeter of the dura or the nerve canal. These wings on that go and attach to the spinous processes will be splayed open, and then on both the top and the bottom we'll splay them open, we'll insert the implant, we'll close them back down, and then we'll use a punch to make a hole where this rivet or screw goes through. This is what the implant looks like. This is the coflex-F. It's a curved implant with the intention of this portion of the curve going down right next to, within 1 millimeter of the nerve canal. And you can see the opening where the rivet or screw goes through. The interior portion of these flanges have a roughened area to prevent them from being dislodged or coming back out this way. And then as a backup and further fixation, these metal screws or rivets will go through the bone and attach to a nut and will be actually screwed down tightly. This is the implant called the coflex-F, which will be involved and utilized in the surgical procedure today. The indications for this surgery on this particular patient include intractable back pain and radicular pain going down the posterior buttock into the thigh and somewhat into the lower leg. Like any patient that undergoes a large procedure like this, they should have had an extensive course of conservative care. Typically, that would include 6 months of symptoms, a course of and trial of physical therapy, perhaps some chiropractic medications. These can include anti-inflammatories, muscle relaxants, opioids for pain relief. We will almost always try a series of epidural steroid injections, and we like to make sure that we know that the pain generator is involved in this particular spinal segment. This patient meets those criteria for surgery. He understands the benefits, risks, and alternatives, and he's agreed to proceed forward with this type of surgery. So those are my usual indications. In addition to that, I have had a large series of use with the coflex-F. I've used it in a large number of different settings. I've used it as an individual posterior fixation device where I've taken off the supraspinous and interspinous ligament complex. I've removed some of the lamina. I've put posterior intervertebral cages in the form of a pliff, and then I've locked this down with the coflex-F implant. Other settings where I've used this is if I've done a trans-psoas far lateral intervertebral cage. Other places where I've used it is to augment an anterior lumbar interbody fusion, which is what we're doing in this particular surgical procedure today. We will do an anterior procedure, and then I can do a posterior decompression and add significant stability by adding the spinous process fixation with the coflex-F. In my experience, what happens is with interbody cages, we can feel like we have excellent fixation with intervertebral screws, an anterior plate, all kinds of different ways of locking this together. But if you then turn the patient into the prone position to do a decompression, you'll see that there's still significant micromotion of the facet joints. By adding the coflex-F implant, you've increased the stability for axial rotation, you've limited flexion and extension, and you've probably significantly reduced lateral bend. I believe that the coflex-F is an excellent fixation device to augment any type of anterior lumbar fixation in the intradiscal space. In terms of post-operative management, I usually have excellent nursing care available for my patients. The patients will be up and walking the same day of surgery. They will walk 2 to 3 to 4 times through the course of the evening, and they will typically go home the next day in less than 24 hours. Most of my patients are started on an IV PCA in the recovery room. Once the initial pain has been taken care of and controlled, usually that evening, we'll switch them over to PO medications, both a long-acting and a short-acting PO opioid. We tend to get the IVs out within 4 to 6 hours after the surgery. As soon as the patient's ambulating in the hospital, the Foley catheter is removed, and almost all of the patients, probably 95 to 98%, go home the following morning. I do not fit my patients with corsets or braces unless it's for pain relief only. I typically feel that the fixation that we get with the anterior and posterior fixation internally is better than external bracing. The external bracing can be used at the surgeon's discretion if he feels like it will help reduce the patient's postoperative pain regimen. I usually have the patients on a postoperative PO pain pill, a narcotic, and some patients feel better with Valium. We are very careful not to prescribe or utilize any of the non-steroidal anti-inflammatories because they do tend to slow down the postoperative fusions. I see my patients back in 7 to 10 days after the surgery. I get an initial x-ray in the office to document position of the implants. I check the wound. I see them again at 6 weeks, 3 months, 6 months, 9 months, and if they're not fused at that point, I'll see them at a year. The fusion rate with anterior-posterior surgeries of this type should be somewhere around 90% with good surgical technique. Autogenous bone graft off the iliac crest can be utilized. Of course, all of this is at the surgeon and patient's discretion, and FDA warnings and labeling should be observed.